I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Afternoon, Jam. Nice to see you. Here we are, a Monday, not a Sunday night, having a chat about another drug that's been approved. We're coming in the run-up to Christmas, aren't we? There's a lot going on, but what have you been doing and what have you got ahead over the next few weeks?
We're recording in the daylight because I wasn't sure that there were actually windows where you are, but it's wonderful to see the light. You are going to America soon, in a few days, for the annual American Society of Hematology meeting. I'm not going this year, but I'll be keeping tabs on it from afar. Are you excited?
Yeah, I am excited. It's a jolly long way to go, though, just for a quick meeting. And I don't know if any of our listeners have ever been to these meetings, but they are crazy, aren't they? I mean, it is literally dawn till dusk and beyond of just downloading information because everything's changing so quickly. And so the amount of stuff to share within these sort of 4 or 5 days is extraordinary. So I'm kind of excited. I'm looking forward to the plane flight home, let's put it like that. And I know I'll be absolutely exhausted, but hopefully lots of things to share amongst ourselves and with our listeners.
I think it's going to be great. I last went 2 years ago and it's like, it's the hematology planes, right? You just see basically a whole bunch of hematologists on the plane. So people sit down and are having a chat and then, some people get their papers out and start highlighting things, and it's like, oh yeah, I'm gonna work in the plane all the way over. And then genuinely, after about 15 minutes, nearly every single hematologist I saw was watching Barbie the movie. People start off with this like, yeah, I work on planes, but it's like everyone was there with their gin and tonic watching Barbie. So I'm sure you'll find some good movies to watch, Sally, but we look forward to updating everyone about key updates for, of course, people affected by myeloma. And there's some very exciting things, combinations of immunotherapies. And that kind of does segue a little bit to what we're going to be talking about today, Sally.
Well, it certainly does, because actually we first heard about the drug we're going to talk about today, Talquetamab, probably at the American Society of Hematology. And, again, like we said on previous podcasts, you hear about these drugs coming through and you think, God, it's going to be a while till, they make it across the pond to the NHS and we can start using them. But here we are, another fantastic development, in our sort of our repertoire now of treatments we can offer people living with myeloma. And so we really wanted to update our listeners about this because it's only just been approved by NICE, another approval this year. So thank you everyone at NICE. We're really appreciating the fact that you're able to support all these fantastic developments that are going on.
So yeah, this literally happened 2 weeks ago. It's a type of drug that we've talked about before this year, a bispecific antibody. So some of you may have seen me doing my bispecific impression on Instagram, where essentially you've got your antibody and then it's able to very cleverly spot the myeloma cell, but also spot the T cell, a key part of your immune system, and bring them together. That's how drugs like bispecific antibodies work.
And that's why they're so effective, because they target the proteins on the outside of the myeloma cells. But rather like when we spoke about the other bispecific antibodies, Jan, the BCMA ones, Talquetamab's different because it's got a different target, but that also means, therefore, it has different side effects, doesn't it? Which we're going to speak about in this podcast.
And what's very exciting is that this target, which again is fairly unintelligible, but it's GPRC5D, which is not quite as good as BCMA for YMCA, but I'm sure we'll come up with a song by the end of the podcast that can reference these combination of letters and numbers. But Sally, when we talk about myeloma, we always get excited when there are drugs that attack new targets, because we're understanding all the time inherent weaknesses of myeloma cells and ways in which to attack. And this is the first drug that's ever been approved for this specific target.
Yeah, absolutely. And interestingly, when someone cottons on, or when the industry cottons on to a new target, then other drugs and types of drugs using the same targets, they're trying to latch onto the same protein, follow. And I think, the story is not over with GPRC5D, our lovely snappy friend target there, in that there will be more, I'll hear a lot about it actually next week, about different types of drugs trying to use the same target to kill the myeloma cell in perhaps a slightly different way. But this one is available now for us, which is fantastic news.
And what group of patients can it be used in, Sally?
Well, to our international listeners, you may have already been exposed to this actually, and indeed some of our listeners in the UK may have already had the opportunity to be exposed to this drug in clinical studies or via the drug company before it was approved by NICE. But at the moment, on the NHS in the UK, this is available to people with relapsed myeloma. So when they've had at least 3 lots of different treatments before, and then they are theoretically eligible to receive this treatment. And that may be, so what we call it 4th line, meaning they've had 3 types of treatment before, or maybe even 5th line or 6th line. So from any time onwards, really there, this drug may be appropriate.
And what is interesting is that even if you've had a different type of bispecific antibody previously, you will still be eligible for this one potentially. It gives us more options and more flexibility, but with choice comes also longer discussions about the pros and cons of using this agent versus others. But maybe if we sort of start at the beginning in terms of the drug, and let's start with how well it works. For that group of patients that you mentioned, this drug was approved with a trial, as all drugs are approved in. What it's showed broadly is that around 2/3 of patients respond to the treatment, and that's sort of specifically in the group that we've talked about already. And on average, the drug may work sort of somewhere between 12 to 18 months, and the drug is given by itself.
You're looking at 2/3, maybe actually a little bit more than that. But I think what's really important to say, and we've said this before on our podcast, is actually what happens in a clinical study may not be what happens exactly in the real world, because you've got different patients living in the real world. If some of our listeners wish to be considered for this treatment, or their doctor talks to them about it, I think the important thing to remember is it's more likely to work than not, which is really important. So therefore, it's certainly worth a try. And again, the extent to which, or the length of response or remission that you get with this treatment might be dependent upon what you've had before. But again, yes, you're looking at many months, and that can extend into years as well. And we know, and we've spoken about this on our response podcast, haven't we, Jan, that generally the better you respond, and by that I mean the lower your paraprotein or your light chains go, the deeper your response, also the longer your response, so the longer the treatment should work for. So everybody's different. It won't work in everybody, but it does work in most people, and therefore in most people you can safely say it will work for a number of months, if not years.
The practicalities of giving a drug like this, so bispecific antibodies, and that's across the whole of sort of hematological cancer, they're given in ways in which you start with a very small dose and then you wait, and then you give a slightly bigger dose, and it takes a bit of time to get to the full dose. We should talk about why that happens, and that sort of leads into the early sort of side effects that we are monitoring people for.
It's interesting you say that, because I almost forgot about it, which is ridiculous, isn't it? Partly because actually I feel quite familiar with these side effects now, and not blasé about them. They're really important, but you just absorb them into understanding these drugs. But I think what you're referring to is the fact that when you're first given these types of treatments, bispecific antibodies, they harness the immune system to control the myeloma, to kill the myeloma. But if you give a big dose to begin with, the immune system's going to go crazy, and you might feel the effects of that, and that might make you feel quite poorly in terms of your blood pressure or your temperature and other parameters. So we go in at a lower dose to sort of gently get the immune system used to the treatments that are coming through. But even at that lower dose, which we slowly increase after a number of days, people can still react, and they can still develop this response that we call cytokine release syndrome, whereby their immune system, the way it's almost overactivated, it affects the other sort of automatic processes within the body, like temperature and blood pressure. But that's one of the side effects of these treatments, and that's partly why we keep people in hospital, often anyway, when we start these treatments.
The cytokine release syndrome, Sally, it's driven by inflammation. And the good thing is that we understand it. We have good interventions. By starting with a very low dose and then increasing up slightly, you're sort of minimizing the risk. Cytokine release syndrome is very common. Certainly, many patients will have it. And when I mean many, 60, 70% of patients will have it, but it's usually relatively straightforward to treat with drugs like paracetamol and other drugs that we sometimes use to calm down the immune system, including steroids sometimes as well. But sometimes when that inflammation is more difficult to control and becomes more apparent, you can actually get inflammation in the brain as well. And this is this condition called ICANS, ICANS. It's a bit of a mouthful, but essentially it's a condition that happens when you get overactivation and inflammation within the central nervous system, And it normally only ever happens after people have had cytokine release syndrome. It's pretty rare with drugs like Talquetamab and Talquetamab, maybe 5% of people approximately. So you don't see a lot of it, but your doctors will be monitoring you and ensuring that you're not getting confused, and they'll look at your handwriting and other things just to ensure that you're not developing that side effect. But if things go smoothly, you often have a dose on day one, and then 48 hours after that, you'll have another dose, and 48 hours after that, you'll have another dose. One of the slight differences and potentially advantages of this agent is that when you end up on the full dose, there is, there are two ways of actually giving it. You can actually give it weekly, but there is an approach where you give a slightly different dose every other week. So, reducing the number of injections down to sort of twice a month.
The burden of receiving this treatment gets less with time. And actually, once you're over the hump in terms of having had the drug, and hopefully, if you did get CRS, it was easy to control, and similarly with ICANS, once that's behind you, that's not going to occur in the future. It's not going to happen further down the line. So that's just something which has front-loaded that toxicity. I think the side effects and the likelihood of ICANS, that's that neurological toxicity you spoke about, Jam, is maybe, I think the study showed it in roughly 1 in 10 people, so it does happen, but it's largely low grade. But really importantly for our listeners, we do need to take this seriously. This is why we do monitor our patients in hospital, but it is nearly always reversible. It gets better, it responds to treatment. And so actually your doctors will talk you through the pros and cons of having this treatment, and they will raise these phenomenon, these side effects with you. But I guess it's just important to say that your team will know what to do with this should it occur, and will talk you through it. So yeah, CRS and ICANS, really important side effects. But I think the more we use these drugs, of course, it's intuitive, it's part of the treatment, but it's not something that I in particular think about as being particularly problematic. However, thinking about this drug and the target, the GPRC5D target, there are particular side effects unique to that target.
You really made the key point. I think just generally about, why do drugs cause side effects? I mean, it's such a crucial question. And that's because increasingly we understand how to target things like cancer cells, but that protein target is often found in different parts of the body. In those different parts of the body, you don't necessarily have your myeloma cells, but the drug's still there, the protein's still there, and the drug goes, oh, there's something to grab onto. And then that tissue gets affected. So this protein, you see a lot of protein in what are called keratinized tissues. Sally, can you just explain what that means? And it does help sort of explain the side effects a little bit, doesn't it?
Yeah, so keratin, actually, some of us, our listeners might be familiar with keratin because it's often on sort of like beauty products, isn't it? Sort of to help your hair grow.
It's on all of mine.
It's on
all of my beauty products. Every single one.
I'll tell you what, I have to douse myself every morning to get over the bags under my eyes. But anyway, I digress. So it's in lots of beauty products, and that's because keratin is actually found in the skin. So it can help with the skin and your nails in particular. But also, I don't know if there's keratin actually in the mucosa of your mouth, but the mucosa of your mouth do express this protein, the GPRC5D protein. And so actually, if you think about the fact that it's related to keratin, this protein, you're going to have problems with your keratin, and therefore problems with your hands and your nails and your mouth, where the target also is, as a side effect of this treatment. So I think it does help to understand why in particular are these really peculiar side effects happening, but it relates to where this protein might else be in the body.
Let's start with the mouth and taste. Clearly, this is not the only chemotherapy drug that affects taste. And every week in clinic, people come in and go, food just doesn't taste the same. And I mean, the impact of that on quality of life is enormous. I can certainly imagine how I would feel if I couldn't eat and enjoy the foods that I like to eat. But it is a particular problem with this agent. I think there's no doubt about that. And the medical term is called dysgeusia. I mean, broadly, it seems to happen in nearly everybody to a greater or lesser extent, certainly over 80% of patients. And there are some things that will make it worse if people have bad oral hygiene to start with, and maybe bad gums, and have had problems with maybe thrush in the past, or had lots of steroids. There are things that can almost tee someone up to have it really badly, but it is extremely common. And it's a very active area of research at the moment in terms of how to minimize the oral effects of this drug, because you can also get a very very dry mouth. So Sally, when this happens, what sort of interventions can help? I mean, when people generally get drug side effects, of course, you can always stop, pause the drug, increase the frequency between doses. What can we do?
Yeah, I mean, it's such an important side effect and really quite unpleasant. I mean, I haven't been exposed to these drugs myself, but witness people receiving them. It's different to nausea, but you can understand how anything to do with food and nutrition is so important, isn't it, for our quality of life? And so anything which disrupts that can have a profound impact on our quality of life and our health overall. The dysgeusia is such a crazy word, that, isn't it? Every time I say it, it makes me sort of semi-smile. But anyway, it's so hard to pronounce as well. But that relates to sort of like an inflammation of the mouth. And then you can get dysphagia, where it's hard to swallow in particular. And then the change in taste that you spoke about as well, Jam. To combat these toxicities, essentially, it's about really good hygiene. It's about really nice mouth care. You can have anti-inflammatories and cleansers to swill around your mouth to try and calm it down. Sometimes actually steroids mouthwashes, they may or may not have a part which could also help. Yeah. And if the mouth gets particularly dry, sometimes artificial saliva is needed just to help with that sort of sensation of being able to swallow your food because your mouth's so dry, or your tongue sort of getting stuck inside your cheeks. Is just quite unpleasant, really. So I think it's managing the symptoms in a way that you can just cope with them, really. If these symptoms do exist, and like you say, they're present in most people, what often follows is a change in your appetite and your weight as well, isn't it, Jam? And I'm sure you've seen that in the patients you've looked after, and I know I have as well. And I don't know what you do to try and combat that, or if you do anything in advance of that.
One thing leads to the next, right? So I think what we call a multidisciplinary approach is really important. So we get the dietitians involved early to come up with, strategies that can ideally optimize, the calorific intake, how much energy people are taking in, and working out what, they can't do, and those other strategies that you've talked about, Sally. So we, do all of those things together. For some people, sucking lozenges can sometimes help. And I don't know, pineapple seems to have a very good reputation as being very effective, like something in pineapple. And as you said, people are looking for different types of the other drugs that may be useful. Certain types of, diazepam-like drugs actually may have a use. And there is actually trials looking into this at the moment. Key things are warning people, and I think getting the right people involved. But, certainly, sadly, I've seen people come off this drug because they can't manage it. It is reversible, I think, is a really important thing to say. And actually, sometimes if you stick with a drug, and I don't know, Sally, if you've seen this, the intensity of it does actually improve with time as well.
Yeah, I certainly would agree that. And the data supports that, really. I mean, these side effects can kick in pretty early, but it may be if you're able to stay on the drug and find your way around it, that they sort of burn out in terms of their severity anyway, sort of around the 4 or 5 month mark. And it's also understanding how to adapt to it. Like you say, pineapple can be great. Some people say if you have foods which are really spicy, so that it just helps enhance the flavour, that can help. Eating little and often with high calorie foods like nuts, for example, that might help. Just ways to get around it to support your nutrition, but also encourage you to eat where you can. So there are a few tricks which can be employed. And I think, we've definitely said this before, but Jan, but I just want to reiterate it. We will learn from our patients receiving this drug in terms of how to support them through what they tell us, be that pineapple or be that having a curry or whatever it might be. The different ways that can help them stay on track with this. And like you say, close collaboration with our dietitian is so important.
It is different using agents like this when people have had a number of treatments and may have picked up other side effects. And, unfortunately, people are less robust sometimes. And understandably, side effects like this are just like the last thing you need after having gone through treatments for a number of years for myeloma. But as you say, I think in real time, we are learning quickly about how to, deal with this combination of side effects. The other major organ that you mentioned, Sally, is the skin. So again, rash is very, very common with this agent. We're used to, as hematologists and myeloma doctors, to dealing with rashes, drug like lenalidomide, cotrimoxazole. These drugs very commonly cause rashes. There are a number of fairly simple things like good, gentle skin care. We may recommend certain types of steroid-related creams, but certainly for the worst rashes, I have given sort of low dose of oral prednisolone, which is a type of steroid, not Dex, which we, of course, have talked about so much, but just a short course of oral steroids, and that does work pretty well.
Yeah, that can work really, really nicely, can't it? And I think, I mean, you and I have seen this as well, Jam, haven't we? It's the sort of the dryness of the skin, which we're used to with other drugs, but the keratin component of the GPRC5D also means peculiarly your hands and feet can be effective. And we've all seen those photos, haven't we, where people, they are taken to make this stick in our minds, I think, as medics, but where patients have been exposed to the drug and just the skin from their hands and the feet can just peel away. So it can look pretty grisly, to be honest with you, can't it? It can look quite shocking, but I think that's where your moisturisers come in, and that's when letting us know about what's going on. And again, that should get better with time. But yeah, particular side effects to do with the skin tend to be more unique to this class of drug or this receptor, this target.
Nails can often end up looking really, unfortunately, very unsightly.
Yeah, they can, can't they? I mean, nails grow really slowly. I mean, in other forms of chemotherapy, we often don't we look at people's nails and you can literally see lines across them where when they had their chemotherapy, it's sort of like the rings of a tree because your nails stop growing as the chemo kicks in. And in here, it's not quite the same as that. But I mentioned that point because nails grow so slowly that even if you were no longer exposed to the drug, it would take a while before your nails grew and returned to normal. But they can get quite brittle. And actually, the nails serve a really important purpose, don't they? They protect our fingers. And so if they're brittle, it could cause problems with your fingers. So actually, when this is a significant problem, sometimes people have to put coatings on their nails to protect them, to keep them hard, or some gloves to help them with their nails as well. So again, there are things which can be employed. Not everybody needs these things. It's not necessarily severe in everybody, in fact, only in the few. But where it is severe, know that there are things that can be done to keep somebody well and minimise that toxicity.
Other important side effects are tiredness and fatigue, which, of course, can be related to what we've already been talking about side effect wise. Low blood counts, which we can monitor, and we have good interventions to keep them up. Something that we haven't actually talked about yet, Sally, is infection, which is unusual for us when we're discussing drugs and the risk of infection. It's a powerful agent. How significant is the risk of infection?
I mean, the reason we haven't spoken about it is we're really aware of it with the BCMA bispecific antibodies. So that's your elranatamab and your teclistamab, because the BCMA sits on healthy immune cells, whereas this target, GPRC5D, doesn't. And so you don't tend to see the same signal in terms of infection. It doesn't come with that significantly increased risk. There's still a risk because there's always a risk. Someone's got myeloma, there's a risk of infection, they need treatment. That risk does not go away. However, it's much less compared to your BCMA targeting bispecific antibodies. It's just less of a concern in our minds day to day. The infections may crop up, but hopefully they won't be quite as severe and not so frequent, but definitely still there, but just not quite as problematic. And so actually we spoke, Jam, didn't we, on the BCMA podcast about intravenous immunoglobulin and the protection that can confer some people. Do you give IVIG to people receiving Talquetamab?
I think it's clear that less people need it. There are standard criteria that we look at, Sally. And as you said, because that other class of drugs that target BCMA, the bispecific antibodies, the level of immune cells, drops in basically everybody and pretty quickly, especially, of course, if they're responding. So they fit the criteria of someone that would definitely benefit from IVIG. And you don't see that in the same way in Talquetamab, which I have to say is a significant advantage if you are someone that potentially is at risk of very serious infection. So, now we have this agent available. And I mean, this is probably a topic for a whole podcast, Sally, to be honest. But again, another question in meetings across the country now will be, well, I have someone who's had 3 treatments and now they're eligible for their first sort of bispecific antibody treatment. Which one would be better for them and safest for them? And one of the factors may be, I just think Mr. X is just going to be too high risk of infection, even with the immunoglobulins. So we're going to use Talquetamab. And then, to turn it on its head, it's like, Mrs. Y, she unfortunately only still weighs 45 kilos and has had problems with her diet in the past because of other health problems. We can't give her an agent that potentially stops her from eating properly and losing more weight because, that would put her at more risk for other things. So what this shows us is that now we have this extra agent, we can start thinking about things in a slightly different way.
I couldn't agree more. And I think what's so interesting and important about this is it is nudging towards personalised medicine. A lot of people are going to have very good outcomes with many of the treatments that we offer them. A decade ago, there's a finite number of treatments and you almost wanted to expose everybody to as many treatments as possible to make sure that they got as good a response as possible and they, to be frank, lived as long as possible. Whereas now, with the treatments being so much better, you don't necessarily have to be exposed to absolutely everything to get the gain. So we can personalise the agents that we choose more to the patient. I mean, it may still be the case that we want somebody living with myeloma to have been exposed to elranatamab and then talquetamab, for example. So 2 different types of bispecific antibody with different targets. But it may be actually we can say we're confident that what we give to you is going to work and it's going to work nicely. So let's try this one first and we'll deal with the future later. So we really are fortunately now in a position to choose the drug to match the patient, which is great, I think, isn't it?
It really is. And to have, more choice, as you say, allows us to, I think, really as much as we can at this point in time in 2025, individualize things.
Yeah, and I very much hope this is it's the beginning of that era, really, in terms of knowing what to give to whom, when. And I think that do you remember the podcast we did I think it was months ago now, Jam, about Sarah? We dipped our toe there, didn't we, into personalisation of medicine and how do you know which drug's going to work in which patient? And I think this is, Talquetamab offers a potential of that alongside the other agents that have come through. So exciting times.
Indeed.
Shall I explore a little bit about these side effects? Because they do crop up at slightly different times, don't they? Depending on when you've been exposed to the drug, just to kind of reiterate and help our listeners in terms of what to expect. So what I'm about to say is based on what happened in the clinical study. And like we know, the real world can be a bit different, but it does give us a guide, doesn't it? When someone starts on this treatment, as we said previously, they're likely to, in most places, likely to be in hospital. That may change in the future, but they're likely to be monitored at least anyway closely for the side effects of cytokine release syndrome and this ICANS issue, which is the sort of neurological toxicity that can go with this class of drugs. And that's for the first week. And generally after you've been exposed to the treatment and you've had those doses increased, the risk of that is then faded and it's passed. And then within the first month of treatment, that's when the side effects relating to the mouth tend to crop up. So that might be the dryness of the mouth or soreness of the mouth or a change in taste or struggle swallowing. And also that tends to be when the skin problems might manifest as well. Skin turns over very quickly, doesn't it? So it's logical, isn't it, that if you're targeting the skin as a new skin grows, it's going to be affected. So that might be dryness or rashes or even those changes on the hands and feet that we spoke to. But nails take a little bit longer. So those issues have been reported to crop up around the second month. So that's where you might notice the nails going a bit thinner as they grow from the nail bed, so closer to the sort of knuckle area and maybe a little bit fragile. Around the third month, if somebody is living with the problems related to swallowing, for example, that's when the weight loss really might be most noticeable. That's when, if you hop on the scales, you might think, oh my word, what's going on here? And also that's when sort of low-level infections might start kind of cropping up. Infections can occur at any time on this treatment, and actually severe infections tend to occur when you're first exposed to it. But by the time you get to sort of month 3, month 4, they should be sort of burning out and relatively low level. And then approximately around the 6-month mark, the taste changes and the mouth changes might still be there, but perhaps a little bit more improved as people know how to manage them, how to get around them. The skin issues should be improving again, knowing how to cope with them, having had all the treatments that's needed. And the nail changes are likely to persist. The problems do persist, but I think as you know how to manage them, they become more manageable. And in fact, in the study, most people were able to stay on treatment. Some of them had a dose reduction, but most people tolerated the treatment. And the other thing to say is, which is really important, in terms of the weight loss, that tends to happen at the beginning, but then gradually, sort of after month 3 and 4, it appears that the weight may pick up, again, as people know how to handle it. So know that it's dynamic. If these changes are happening to your body, they won't necessarily be that severe for that long, and there are things that we can do to get around them. So really important to say, talk to your doctors. We always say this, don't we? Talk to us, let us know what's going on, let us help you through it, and then hopefully we can keep you on treatment, keep the treatment working, and keep you well.
It's those initial things that happen in month 1 and 2 that then cause the weight loss to sort of really kick in month 3. But as you say, I think we are understanding things very quickly now with this drug and the side effects of this target, and we're getting better at managing the side effects, which of course is what we need to do. I think one final thing to say is that increasingly with drugs like this, in different parts of the country now, people may not be an inpatient, but given these drugs in what we call an ambulatory facility, whereby you go home after each dose, but you're sort of monitored intensively remotely, through phone calls and catch-ups, and we'll monitor your temperature and other bits and pieces at home just to make sure that you're not getting any of the early side effects. But also, if you do, there are clear mechanisms for what you do, whether it be take specific medication or and usually come back in for an assessment. So we're getting better at working out how to give these drugs in a way that are also better for quality of life, which is broadly being in your own home.
Yeah, definitely. And actually, maybe we should do a separate podcast on the whole ambulatory piece. But I think this service may or may not be available in your local hospital. It's quite likely to be more available in more hospitals, I think, in the future, isn't it, Jam? And I think that also goes with how we understand the drugs, but also how we understand our patients. How active is their myeloma when they're going in with this treatment? How likely is that myeloma to react to the treatment as it goes in? So all these factors will come into play. And ambulatory pathways, I think, can be absolutely brilliant, can't they? But even if you are being treated in a hospital where they exist, your doctors may still say, we want to admit you because there might be something particular about your myeloma, which means they just want to keep a slightly closer eye. But yeah, fantastic. I think that will be the future, won't it, really, for managing these people on these treatments?
Definitely. So there it is, Sally, another new approval of a new drug, a brand new target, but with this technology of bispecific antibodies that, can be, very effective for certain groups of people. Another choice, another option, and hopefully that will continue to mean, improving outcomes. So we're all very excited that it's here.
Absolutely. And as we go into December, it's been a record-breaking year, hasn't it, in terms of nice approvals? It's brilliant to have another one to talk about in the last month of the year. And let's hope that 2026 delivers the same for everybody living with myeloma.
Absolutely. Sally, have a great trip to the States for the American Society of Hematology. And our next pod is going to be our Christmas special, whatever that means.
We'll be wearing tinsel and...
Anything could happen at the Christmas special. I think we have to work out what is going to happen, but we look forward to chatting then, Sally. There may be some special guests, and I think we're going to hopefully do a summary of the year, because it's been a big year in myeloma. A lot's happened. Lots of things are now available that weren't a year ago. So it'd be nice to take the wins and talk about them. And also then, as we start 2026, we can talk about what might happen next year as well.
Yeah, brilliant. Can't wait, Jam. Looking forward to it. I'll have a burger for you. Yeah, or whatever.
The best thing about the States is the burgers. The worst thing is the coffee. I won't miss the coffee, but I will miss and the music. Sorry to all our American listeners. This is terrible. We'd actually, please contact us most. You have the best burgers in the world, and I'm going to say it, the worst coffee in the world. Oh my goodness, maybe I shouldn't have said that, but the burgers are the best. And thanks everyone for listening, and we'll see you at the next one.
Bye.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.